You have to put a program together, that team that we talked about. You have to set up some protocols, which I'll just run through quickly because I just don't want you to think you're going to get your outcome without a lot of hard work up front. Once the hard work's done, the rest is fun and it gets very easy. So we just, we evolved into 2 centers of care. Once we had the software, a group of physicians signed up for it. It's a little bit of a pain. And then the other group didn't want to be, they're doctors, they want to be independent. So we had a nice study. We had a group that followed protocols and a group that followed their own protocol. I have no financial interest in anything in medicine to include the software that we're talking about. We're a large hospital, 500 beds. It's important, I think, to realize that now with software, you don't have to be in a university. You don't necessarily have to have a lot of smart people, that any facility can do this. And we did the study in 1912, and just you have to change and people have to change. So you cannot be what you need to be by remaining who you are. So once you make a commitment, I think the leader has to undergo the most changes, and then the rest of the staff has to also. These are reasons the surgeons didn't want to do it. There are too many obstacles. There's no positive benefit for me. Actually, many things are about me. Efficiency is more work. It is more work until it's set up. Then it becomes very efficient. They always think their way is better than my way. That's when they need to be thrown off the boat. It's your way or my way. And, of course, it won't work. And this is what I mentioned earlier about when you're going through all this process, which I call the sea of change. You have more no's than you have yes, and if you don't have strong fortitude, your boat's going to sink. And when you look for leadership, you don't necessarily have to go big time, which is the tendency companies and hospitals want to make. Larger-than-life celebrity leaders who write in from the outside are negative correlated with taking a company from good to great. So usually there's anybody in the hospital. I think I could help Joe out. I think with my background now in data collection that I don't have to be an expert in anything except how to manage outcomes. And I think once you get that concept that you can come in and manage anything. As I said, most of the services that I've managed have not been within my own discipline of orthopedic surgery. And if you want to, everybody always wants to know, well, what do I need to read? I think the most important book for leadership, if anybody's just going to manage, is still 7 Habits of Highly Effective People. That book has sold 25 million copies. It doesn't mean 25 million people have read it, but it's a very popular and very good book. I like the next 2 equally as well, Jim Collins and In Search of Excellence. And raving fans will not get any kudos in orthopedic surgery, but trust me, if you read this book, you'll understand how to manage your patients. And once again, going forward in 2018, having raving fans is going to be hugely important. I also just love the Peter Principle. Dr. Peter was from LA, worked at USC as well. It's a long forgotten book. It's 50 years old now, but he just tells the hierarchy, and everybody works within a hierarchy, and many of those laws that he describes, which most people just remember the Peter Principle, that you continue to go to your highest level and then you become incompetent. So we have many incompetent leaders. That's always important to remember when you're sitting across the table from one of them. And then you have to have the team that we talked about that has to be put together, and it has to be patient-centric. So always when you're having battles within your team, you always have to say, listen, what's more important, you winning this battle or improving patient care? And it takes a long time. Peter Drucker talks about just writing a mission. You should have a mission statement. This is the mission statement I made for our facility, which is replacing arthritic joints with artificial joints using precision surgery. Precision surgery is our robotic surgery with minimal complications. That's with our data collection. And then we like to think of our floor as a wellness environment. We have our own floor for the total joint patients. They have their own nurses. We have individual rooms. Most of the rooms in the hospital have 2 people in them, but on the joint service, they have their own room. And as I mentioned, this is when I became the medical director, and my first goal was to do outpatient surgery, which I did within the first year of setting it up. And then we hired the physician assistant, and then she helped me push through the protocols to the rest of the team because she's a nice person. She actually spent 5 years here in Baltimore with one of the most highly regarded total joint specialists in the country. And then we had enough money, and we eventually purchased the robot. So then we fill in with very creative ideas. One thing we did was just to go, most busy orthopedic surgeons run 2 rooms. We actually tried running 2 surgeons with 3 rooms, so 2 surgeons start at the same time, and then there's an empty room, and whoever's winning the race, the physician assistant keeps her eye on everything. She's a triage in the operating room more than assist. She sets the next room up, so if I finished first, I would go into the 3rd room. My room would be set up, and the other orthopedic surgeon would then go into my room. And then chances are I would go back into his room once it was cleaned up. So it affords you to do very innovative things when everybody works as a team. This represents our service. Monday's our biggest day, so we really fill the service up Monday. The patients are discharged. We have a bigger wave come in on Wednesday and then a smaller wave on Friday. We like the service empty by the time Monday morning starts. This is a popular slide always of the whole is greater than the parts. So we have 4 teams really, but the patient experience should be 100%. Each one of these teams has processes. So the surgeon has a lot of processes that they go through, which is one reason surgeons didn't want to be part of it. The hospital as well. The pre-op class, I think, is one of the most important things in the hospital, 2 hours every Monday morning. Then they go to pre-admission, do the lab, their screening and everything. We had a lot of trouble with anesthesia, which is not uncommon. There's 20 in their department. They couldn't come together with the protocol for me, so I wrote the protocol for them. And then most importantly is the patient itself. We are really keen on patient engagement. They have to come to the pre-op class. They have to bring somebody with them, which we call a coach, and we have them come back at 3 months after their total joint and tell us what they liked and what they didn't like about our service. So they're really empowered to also help make us a better service. We do a lot of marketing. This is a nurse in the hospital who we did as an outpatient at Total Hip. He was back working within a month, but this is kind of what happened to him. Since the launch of our service, we've had a marked reduction in our hospital stay, which has generated a lot of money. Once again, in a Medicare patient, as long as they don't go to a nursing home or an ECF, if you discharge them early, that's extra money in the bank. This is our decrease in transfusion rate, when 33% when we started, down to 5% when we did the study. Just in blood clots alone, that's $500,000. But remember, if you transfuse a unit, that means you're going to be in a day to a day and a half more. So that translates really into $1 to $2 million in savings. And this is our database, which we mentioned earlier today, and then we can drill down. So we'll just take the clinical and we'll look at transfusion, since that's an easy one. And we can come down and see what our transfusion rate, then we can drill it down even further to look once again at our entire system, what our the Marshall Steel benchmark would be, what our goal would be, and here's the best person in the system, what that hospital does, and of course I've set our benchmark to be the best in the system. And after we do the study, which I'm just getting ready to present, this is one of the, once we did the study, the hospital would never let us have 2 tiers of patient care in the hospital. We subsumed all orthopedic surgeons, so now they're all part of the total joint program. And here's one of the doctors who, at this time, just after the study, was still transfusing at about 50 to 60% of his patients post-op. And now, just even after coming in within the first year, he's down to about 20%. So in another year or 2, he'll be like the rest of the service, will be transfusing less than 5% annually. So total joints is a huge cost. It's the largest cost to Medicare in America. That's why we're now going to bundle payments. And as I mentioned, high volume surgeons have become a big issue because they have less complications in high volume centers. So it's really important that you know where you fall into this. And this is how we're actually going to look at the study, because I want to help the low volume surgeon. I want to help patients, but I also want to help low volume surgeons so that they don't have complications. So this is just from the literature. Once again, more than half of the total hips in America are done by surgeons who do less than 10 cases a year. This is really a problem. And Bozic stated that the surgeons in the lowest quartile of total hips have higher complications, readmission rates, reoperations rates, longer hospital stays. This is a huge problem for us. Huge problem even in our own center. So Katz made this statement, which we disagree with slightly, that the data suggests that experience, the high volume, and the developed systematized approaches. You can't just do a systematized approach. You have to collect the data and do outcome studies. Just because I give you a protocol is not going to make you a better surgeon. And look at the admission rates across, this is across the country through Medicare data. Total hip admission rates, 7% at 90 days. Total knees is really higher. This is across the country. All orthopedic surgeons think they don't have readmits. I got news for them. They do, even high volume surgeons. So this is, once again, transfusion rates. They've actually gone up from 2000 to 2009. I think the reason was because we were doing the auto transfusion back then, and we moved away from that. So something caused actually a higher transfusion rate than lower transfusion rate with time. They're much lower now than that, I think mainly secondary to TXA. So this is the study that I've been talking about. Now that we're all set up, I like to begin with the end in mind, so I'm going to tell you the conclusion. We think it's effective leadership implementation data collection with continuous review that improves performance for all, high volume as well as low volume, but mostly the low volume surgeon. So we took calendar year 2012 and we compared the surgeons. Group 1 will be the surgeons who are in the Joint Replacement Center program, and Group 2 are those that are not. Group 1 also has some high volume. So high volume will be Group 1A. Group 1B will be the low volume surgeons. All the surgeons, as you might anticipate, in Group 2 were all low volume surgeons. So most of the data really is going to be between Group 1B and 2, because I want to really show the difference between low volume surgeons, how a protocol can help low volume surgeons, which I consider this to be a problem in our country. So these are just the outcomes that we did: blood transfusions, complication rates are the skip rates, mortality, 30-day readmission, discharge, length of stay, and this is how we statistically looked at our outcomes. Our Group A, we had essentially 350 cases. Our Group B, we had 150, and we had 100 in the Group 2 cases. And if we look at the blood transfusion rate, our low volume surgeons in the program had a 20% transfusion rate, and look at the surgeons in the non-surgical program. Really a huge statistical difference. Even between this group is, but it's really narrowed down. Year 14, we were almost the same. With time, most of the low volume surgeons equal the high volume surgeons. So this is our discharge to home. Once again, this is hugely important now in bundled payments, and this is exactly why the hospital wanted the non-participating surgeons, our program. Half of their patients went to nursing homes. And when you look at our low volume surgeons, 70%, we're now up to 92% for the entire service. When we look at length of stay, huge difference between, statistically, not much difference between our two Group 1A and 1B, but look at the difference in our length of stay with the non-surgical or our non-joint patients. Really statistically significant. Big difference within the readmission rate, also between the Group 1 and Group 2 surgeons. Complication rate, also big difference between the two populations. And if you look at our 1A and 1B, they're almost the same. That's the beauty of data collection and self-improvement. We only had one death, and so statistically it can be different. Can't be statistically important between any of the groups. Happened to be in one of the 1B patients, one of the lower volume surgeons in the joint center group. And our conclusion from the study is that participation in a program is a determinant for positive patient outcomes. The high volume surgeons still had the best outcomes. The low volume surgeons actually approach the high volume surgeons that are in the joint service, and they certainly statistically in every category outperform the non-joint replacement center group. So we agree with Katz up to a point. High volume does matter. I don't know that he could say, I think he just concluded, because when he looked at the data, he was looking at high volume who had some systematic approaches. But just once again, a systematic approach for a general orthopedic surgeon will not lead to a better outcome. You have to have implementation of some guidelines as well as data collection with continuous improvement for the low volume surgeon. And these are just the references relating to volumes and outcomes. Any questions?
Sir, if you permit me, I can ask a little different question. When you select a case between degenerative osteoarthritis and inflammatory arthritis, as far as TKR is concerned, total knee replacement, what are the possible complications you expect out of an inflammatory arthritis joint compared to a degenerative arthritis joint? Because according to my knowledge,